Okay, this tape we're going to start talking about toxicology, the management of the ingestion or inhalation or burn with toxic substances. All right, many of these patients will be suicide attempts. Okay, the boards can frame this question as somebody's brought to the ER unconscious. It could be framed as a question of someone who is attempting suicide by the various methods, or it can be a patient who arrives unconscious with particular signs or symptoms or laboratory tests that should make you think immediately of a specific toxin. So let's go through the common toxins you're going to see, and I doubt that you'll see any toxicology questions that we're not going to cover the substance right now. A 25-year-old medical student goes home after class, finds no messages on the answering machine from his girlfriend. In a fit of despair, he takes a full bottle of pills in an attempt to commit suicide. He takes the label off the bottle of pills in order to prevent any attempt to reverse the poisoning by identifying the specific agent. Immediately after doing this, his girlfriend calls. He immediately runs across the street to the nearest emergency department and walks in the door 30 minutes in total after the ingestion, saying that he's now changed his mind and wants to live after all. He does not want to tell you the specific name of what he took, which is a little peculiar since he wants to live, but make the assumption that he took a bottle of unknown pills, and he wants to know what's the next best step in management. Now, let's talk about the general approach to the patient with an overdose. Just like we talked about the general approach to the patient with a potentially life-ending arrhythmia. The most important initial information you need to get is from the history. They will often give you a patient's medical history, which should suggest which medications the patient is on. Remember, suicide is attempted usually by depressed people. People who are a little manicky or euphoric are unlikely to try and kill themselves. People who are depressed are trying to kill themselves. What do people who are depressed do? They take antidepressants. And when the antidepressants aren't working so well, they take lots of antidepressants to kill themselves. So remember, someone who's very depressed, right away you think about antidepressants. And the ones that present with severe symptoms are the phenothiazines. And we don't use phenothiazines very much, in part because people try to kill themselves with phenothiazines. And the newer drugs like the SSRIs, you're not going to see significant overdose complications. So it's the patient history. If the patient's a diabetic and is found unresponsive by someone in their home, what's the most likely scenario there? There's obviously hypoglycemia. If a patient has a history of drug abuse, or on the question stem, they tell you has multiple evidence of old cellulitis, or has a history of endocarditis that's not explained by any other reason. Think about IV drug abuse. And now if the patient's coming in, we'll talk about the specific physical findings of narcotics in a few minutes, but there you're going to think about narcotic overdose and you'll treat that patient appropriately. So again, the history alone, without giving you any more specific information about what the overdose might be, might give away the diagnosis. And we'll talk about some more of these sort of key clues from the history. And how will this present itself as a choice in the question, in the choices to the question? They might say, call the relative to go home immediately and find out what the patient has at home. Bringing in the pill containers is an important step. And that is not a silly choice. The patient is not about to die, and the first choice might be, if the patient is stable, send someone home, bring in the pill containers. That will help you guide therapy. Sometimes the therapy for one particular kind of overdose might be contraindicated in the patient with a different kind of overdose. Okay? And we're going to look at the history, and we'll look at the information we're given about the physical, and we'll go through the various physical findings in a few minutes. And then we're going to move on to the general management steps. Gastric emptying methods are appropriate in a specific situation and nowhere else. And that is, I want to empty that patient's stomach if I know the ingestion. If the question tells me the ingestion has been within the last hour or so. After 2 hours, there's nothing left in the stomach, should be your assumption. The stomach has emptied, and doing something to empty the stomach is not effective. So don't waste time doing gastric emptying if the ingestion, if you're told the ingestion is more than an hour, especially 2 hours. How do you empty the stomach? Well, the simplest way is to make the patient vomit. And for overdoses, particularly in kids, where they're drinking or swallowing things that they shouldn't be, excuse me, and it's witnessed, you should have some Ipecac at home. Give the child the Ipecac, or if the adult comes in and tells you they just ingested something and they're fully awake and alert and not at risk for aspiration, because you're giving Ipecac, it's an emetic. Patient will start vomiting violently, and hopefully will put that whole pill container at your feet or on your pants as they're vomiting this stuff across the room. So again, Ipecac if the ingestion has been recent and if the patient is fully alert, because you don't want the patient aspirating. Ipecac is one way. The second way to empty the stomach is by putting some kind of tube into the stomach and then lavaging it out. And the name of this tube is a huge orogastric tube. It's called an E-wall tube. And it's about this big. Now imagine having to put a tube this big in a patient's mouth and down the esophagus. It's not easy, it's extremely uncomfortable, and it puts the patient at tremendous risk for aspiration because it's compressing all the structures in the neck here, and you're not going to have an effective gag. We rarely use the E-wall tube. It's not quite this big, but that'll help you remember. If you are going to put down an E-wall tube, if the patient has had a massive ingestion and is not with an intact mental status, so you cannot give them Ipecac, and it's a recent ingestion, and so much so that they are with an obtunded mental status, then you think about doing an E-walled tube or large bore orogastric tube to empty the stomach. But before you do that, in this somnolent or obtunded patient, you need to intubate the patient to protect the airway. We might also get some benefit if the patient has respiratory depression, but the concept here is protect the airway by intubating the patient. Okay? It might not be a patient who needs to be intubated for very long. If I get to the patient early, I put down that E-wall tube, suck out the remaining pills in the stomach, patient might wake up fairly soon and be extubated very quickly. Again, gastric emptying, either with Ipecac in the fairly awake in the patient who's awake and not at risk for aspiration. If the patient has early ingestion, again, both forms of gastric emptying is just with early ingestion. Ipecac in the awake patient, an E-wall tube after intubating the patient in the less alert or obtunded patient. So those are to be used only if the patient, if the question makes it clear that the patient has had the recent ingestion. What other general measures do we have? Well, another very effective general measure, and again, now we're talking about the more frequent occurrence, where the patient is several hours after their ingestion. Charcoal is a good general approach until we know the specific agent the patient has ingested. Why is that? Because charcoal is a non-specific binding agent. If I give charcoal, it'll pass through the stomach into the small bowel, hopefully bind up any pills or toxic substances that are still in the intestinal lumen, and then with the addition of a laxative, a cathartic, the patient will evacuate it through the GI tract. Okay? Remember, if it's up high in the GI tract, it's early. It's 1 or 2 hours. Bring it out this way. If it's later, several hours, bring it out from the back end. Give the patient charcoal. It'll bind it up. Give the patient some laxative. It'll empty it out. Now let's say I see huge numbers of pill fragments in the patient. Another way to empty the GI tract, if, again, several hours after ingestion, the pills are visible on an X-ray, and they are further downstream than the stomach, because if it's in the stomach, I'll empty this way. If it's in the small bowel, I'm going to empty it back door. I can give the patient a rapid flush. I can give the patient some charcoal, and at the same time, I'll be giving a laxative. The most effective laxative to flush the pills through quickly is one of the electrolyte lavage solutions. And they're generally known as Golite, Recolite. They are osmolar solutions that will flush everything through. And you give the patient rapid infusion, so rapid that they're not going to drink it, but you're going to put it down a nasogastric or an orogastric tube, and you're going to flush the gut, hopefully evacuate all the pills before they can be absorbed. Rarely do we attempt to clear the body of the toxins with dialysis. We talked about clearing this way, clearing back way. How about clearing through the urinary tract? Well, it's less effective in terms of it's slow. It's going to take some time to get that patient hooked up to a dialysis machine. It's going to take some time for the dialysis machine to filter all that stuff out. Dialysis is really never going to be your first or second or even third choice unless you're talking about specific toxins, which we'll get to in a few moments, where dialysis might be necessary. But in general, you're not looking for renal clearance with dialysis. Similarly, forced diuresis without dialysis, where we say, I just said dialysis takes several hours, get the patient hooked up to the machine after putting in some large catheters. How about I give the patient some intravenous furosemide and make the patient pee up a storm? Well, again, that's not a very effective route because, again, I got to clear things first through the GI tract if I can. Only rarely will I try and get it out through the urological route. The exceptions to the rule I said that you'll rarely do a forced diuresis is, again, in specific situations where you have a specific toxin, and those toxins are phenobarb and aspirin. Okay? Again, the GI tract is our route of getting rid of these toxins. Lastly, in terms of a general approach to any patient who comes in unresponsive, and again, we're not talking about unresponsive without respirations, without pulses. We considered that already on the cardiac emergency tape. We're now talking about an ingestion of some sort. Patient has a pulse, has a blood pressure, has a respiratory rate, but they obviously have an altered mental status or they're comatose. These patients should all get the so-called cocktail. What cocktail am I talking about? We're talking about a cocktail that includes naloxone, brand name you might recognize as Narcan, high concentrations of dextrose, or we'll call it D50, which means 50% dextrose, and thiamine. I'm not so smart that when the patient comes in, I can tell for sure that this patient has a narcotic overdose, or a Wernicke's encephalopathy that needs thiamine, or hypoglycemia. In cases where I'm not smart enough, the question has not given me enough information to nail down a diagnosis, I'll give all three. Clearly, if the patient comes with a needle hanging out of his arm with heroin labeled on the needle, and the patient has all the findings of narcotic overdose that we're going to talk about in a few minutes, that patient doesn't need the D50 and the thiamine. That patient just needs the naloxone. Okay? But in case the patient comes in without enough information in the question to suggest what the specific etiology is, in addition to all the lavage situations, if I know the patient has a toxic ingestion, I'm going to give naloxone, 50% dextrose, and thiamine. Okay, let's talk now about some more specific kinds of toxins that were ingested. We just talked about the general approach to the patient with a suspected overdose, or the patient who presents with unconsciousness of unknown etiology. And typically the naloxone, the dextrose, and the thiamine is given out in the field. If the paramedic could get an intravenous route or even a little butterfly needle, they'll push the Narcan, the D50, and the thiamine. Okay, let's move on to the case. A 38-year-old man comes to the emergency department 4 days after the ingestion of a full bottle, 60 tablets of extra-strength Tylenol. On the exam, it won't use the brand name. It'll say acetaminophen. And he's complaining of vomiting, right upper quadrant pain, and the question tells you he has an elevated bilirubin, AST, which is also known as the SGOT, and elevated prothrombin time. So we got a toxic ingestion, and we have liver disease, acute liver failure. Why can I call it liver failure? Most importantly, because the prothrombin time is elevated. You can get jaundice without liver failure. You can get an elevated AST for many, many reasons without liver failure. A patient with liver disease who has a prolonged prothrombin time, or INR, that patient has disease in terms of synthetic function. That liver is failing. The other tip-off that a patient might have with liver disease has a failing liver, which needs to be approached very differently than just the inflamed liver, is the patient might have encephalopathy. The two worrisome signs in general in the patient with liver disease in terms of liver failure are elevated ProTime, or INR, and encephalopathy. And in the acetaminophen, the organ we're most concerned about is the liver. Now, this question gives us a lot of specific information. Number one, it tells us that it's 4 days. So am I going to use Ipecac? Am I going to use an E-wall tube? Obviously not. And I know that the patient has taken acetaminophen. Furthermore, I know the dose the patient has taken. It's a little bit super therapeutic. He's taking 60 tablets, 500 milligrams each. That's 12 grams. A little bit higher than our usual dose. And we know for Tylenol, for acetaminophen, we know the specific dose it takes to produce toxicity, which we don't know a specific dose for most other toxins. In those cases, it's very variable. It's pretty predictable, though, with acetaminophen. And if they've taken 140 milligrams per kilogram, then it's very likely that they're going to run into severe acetaminophen toxicity. And that patient who you're told the dose, you start treating right away for acetaminophen toxicity without waiting even for blood test results. Okay? Let's say it's a 100-kilogram male. It's a big, fat 38-year-old. It's an easy multiplication. 140 times 100. This guy's taking 14 grams. Excuse me. Let's make it, because if it's 14 grams, he's only taking 12. So I wouldn't think he's going to be toxic. Let's say it's a little skinny 38-year-old who's 50 kilograms. 140 times 50 comes out to 7 grams of acetaminophen, and we're told this fellow has taken 12 grams. So I know this patient is going to develop the signs and symptoms of acetaminophen toxicity. Now, what are the signs of acetaminophen toxicity? Early on, it's just from the irritation of the stomach from all that acetaminophen that patient's thrown down. And that's going to be nausea and vomiting, non-specific symptoms. And other than the nausea and vomiting, the patient has no signs of liver disease. It takes several days, not hours, several days, 2 to 3 to 4 days, typically 3 or 4, to develop the signs and symptoms of liver disease. Within those couple of days, there might be that window between the early nausea and vomiting and then the signs the question will tell you that is clearly liver failure. There's a window, let's say the first 24 to 48 hours, from 24 to 48, where the nausea and vomiting is stopped because the Tylenol is all out of the stomach, the liver failure hasn't started, and the patient looks surprisingly well. Again, don't be fooled by a well-looking Tylenol overdose, all right? If the patient looks perfectly well at 36 hours and they've given you the dose of Tylenol that implies an overdose, meaning 140 milligrams per kilogram, you start treating the patient right away. You don't wait for symptoms. You don't even wait for your Tylenol levels to come back. Which brings us to the concept of Tylenol or acetaminophen levels. When you measure acetaminophen levels, as important as what the actual acetaminophen level is how many hours have elapsed from the time the patient took that acetaminophen. If I, on camera, right now, take 1,000 milligrams of acetaminophen, in 1 hour, my level might be way up here. 1 hour. Let's say this is 12 hours. Let's say this is 24 hours. Let's say this is 48 hours. At 1 hour, this is considered a perfectly therapeutic range dose. 1,000 milligrams, 2 extra strength acetaminophen. Please don't start treating me an hour from now for this level. If, on the other hand, that well-looking patient says, you know, I took too much Tylenol, I was nauseous, I was vomiting, I was trying to kill myself a day ago, now I feel fine, it's a day later, and this patient's level is up here, that patient is very toxic because the levels should be coming down, obviously. And even levels that are around here at 24 hours might indicate a severe overdose. So you might be given the actual dose the patient took, or you might be told what their level is at a specific time. Obviously, you don't need to memorize what level at what time. You'll be given a nomogram, and you'll be told that at 24 hours or 36 hours, that window where they could trick you into thinking this is a normal, healthy-looking patient, the level is like this, and it's in the, at this point, anything, and let's say the toxicity curve looks something like this, meaning under here is an appropriate serum level, above here is a toxic level. Even though this looks like a fairly normal level, if they tell me it's many hours out, I'll look at my nonogram and I'll see if this is higher than the acceptable rate. If it's higher than the acceptable rate, I'm going to start treating the patient immediately. Now, out here, we're obviously not going to give the patient gastric emptying maneuvers because it's been absorbed way long time ago. Remember, gastric emptying only the first hour or so. This patient is way down the road. The specific antidote, and we don't have that many toxins for which we have a specific antidote, a specific measure to reverse the complications, but for acetaminophen, the antidote is N-acetylcysteine. What happens in patients with acetaminophen overdose is initially the acetaminophen is metabolized by the liver. With this barrage of acetaminophen to the liver gets overwhelmed. And the patient's metabolites of acetaminophen will deplete the levels of glutathione that we need in the liver, and N-acetylcysteine will replace that. So it counteracts the effects of the acetaminophen overdose. N-acetylcysteine. How do we give this? We give this orally, and we give this every 4 hours. When do we give it? As soon as we know the patient has a Tylenol overdose. If the patient has a Tylenol overdose here, even if I'm doing gastric lavage in the first hour gastric lavage, and then start the N-acetylcysteine. I don't want to take any chances. I watch the patient vomit a bunch of pills, but I don't know how many got by into the stomach, through the stomach, into the small intestine, and are going to be absorbed over the next day or two. If there's any question of residual Tylenol or Tylenol toxicity, your knee-jerk response should be go to N-acetylcysteine every 4 hours. And then the patient will gradually, hopefully, recover their liver function. Obviously, if the patient has synthetic liver dysfunction that's well advanced, that patient's going to die no matter how much acetylcysteine you give. So it's important, I can't stress enough, how much you need to automatically think of N-acetylcysteine to start as early as possible in the patient who you know is acetaminophen toxic. Let's move on to our next series of ingestions, and that is at the opera, you go to see the three tenors. Any jokes that are funny, I take credit for. Any cases that don't sound too funny, someone else wrote this. I didn't write this one. All three tenors exhibit confusion, ataxia, lethargy, drowsiness, and slurred speech. And here comes the funny joke, which is to say you're really going to see the three drunk tenors. How will you distinguish between the tenor drunk on methanol or ethylene glycol from simple, good old ethanol, what we use in our alcoholic beverages to give us that particular feeling of intoxication? All three of these tenors seem intoxicated, which loosely defined means change in their level of cognitive function, confused, slurred speech, maybe in advanced stages delirious. Sounds like an advanced drunk. But the question will tell you clues that the patient has not had an alcohol overdose. This isn't just a bad drunk coming in with too much drinking, which can be fatal. And we'll talk about the approach to all of these kinds of ingestion. It's important to remember that the desperate alcoholic will drink anything that sounds like or smells like alcohol. And they'll drink things like wood alcohol or methylene glycol. Where do you find methylene glycol? Well, you can find the hardware store. It's called wood alcohol. You could find it in the paint store because it's used in paint thinners. You could find it in the automotive store because it's in the windshield wiper fluid. I don't think the board would ask you to know what substances contain this, but they might. And so I'd recognize which fluids might contain methylene glycol. It won't be your only clue in the question. They will also tell you something specific about this methylene glycol patient. And that is that this patient has a symptom that you don't see in the typical drunk, is that they have an acute change in their visual acuity, even to the point of blindness. And I'm not talking about the patient who's delirious and see things that aren't there. That patient's seeing too much stuff. I'm talking about a patient who can't see after an alcohol injection, and the patient has that clearly in the question, it's methylene glycol. What else could the desperate alcoholic drink? They might drink ethylene glycol. Where's ethylene glycol found? Most commonly in antifreeze, which for a big gallon might cost you $2.50, $2.50. You get a full gallon of alcohol. Unfortunately, that desperate alcoholic will do anything to get some alcohol, doesn't know that the ethylene glycol is much more toxic and a lot less fun than a gallon of real alcohol. What will tell me that the patient has an ethylene glycol ingestion? They're not going to tell you that a patient is wheeled in by the EMS with a bottle of antifreeze in his back pocket. They're going to give you some specific findings on the physical or even the urine analysis that make you think of ethylene glycol. And that is that ethylene glycol is metabolized in a way that produces oxalic acid, which will produce oxalate crystals in the urine. So if you got a drunk and they show you a urine analysis with rhomboid crystals, say, why are they showing me a urine on a drunk? It's because they want you to look for those crystals and know that that patient has ingested antifreeze that has ethylene glycol. What else can the alcoholic easily get their hands on? Maybe even in your office, in the exam room. While you're waiting to see them, they look for that rubbing alcohol, that smell you have in doctors' offices. That's from rubbing alcohol. The little alcohol wipes, that's rubbing alcohol. That's isopropyl alcohol. Patient will look intoxicated, but the patient will not have ethanol in their system. Now, we can measure for all of these things, but it takes some time. So the question will make it clear what they may have ingested, so you start treating the patients. Methylene glycol is metabolized to formic acid. We said ethylene glycol is metabolized to oxalic acid. It is not the methylene glycol or the ethylene glycol that is particularly toxic. What it is the metabolite is toxic. Turns out that both of these reactions are catalyzed by alcohol dehydrogenase. Now, why is it called alcohol dehydrogenase? Because what alcohol dehydrogenase is meant to do is to detoxify alcohol. Ethanol is metabolized also by ADH to acetaldehyde. Now, if I got to prevent the formation of these toxic byproducts of these non-ethanol alcohols, why don't I try and use my ADH for something else? Give the patient lots of ethanol. After all, that's what they want in the first place. Give them lots of ethanol, and the alcohol dehydrogenase in the patient's system will preferentially work on this. So there won't be alcohol dehydrogenase to metabolize this or this. So the alcohol dehydrogenase goes to work on the ethanol. You don't form the toxic metabolites. Okay? How do I give the ethanol? I'll give it by intravenous solution. Okay? There's a new inhibitor now available, fomepizole. And if they give you that as a choice, fomepizole, I would choose that, because obviously giving high dose of intravenous ethanol is not without risk. Now, we talked about the specific clues of these agents. Blindness, oxalate crystals, maybe renal insufficiency, isopropyl alcohol. We didn't mention the tip-off here might be that they give you a laboratory value that there's an elevated anion gap. Ketosis without acidosis. That should make you think of isopropyl alcohol. Okay? What are some other clues that the patient has ingested some non-ethanol alcohol? They might tell you the patient's intoxicated, and the first thing you drew was an ethanol level, and the ethanol level is 0. So they look intoxicated, they're behaving like they have alcohol. Yes, they have alcohol, it's just not ethanol. These are all clues before you get your more specific measurements. And if you find out that it's one of these, again, the treatment is going to be either intravenous alcohol or fomepizole. Okay, let's move on to our next toxin. Let's take a break here. Let's move on to the next case. An elderly woman with osteoarthritis comes to the emergency department with dyspnea, intractable nausea, vomiting, and tinnitus. Now again, at this point, and I've discussed this on other tapes, can be an extraordinarily broad, an extraordinarily long differential diagnosis. But if I were to look at the bottom of the question, let's say not this question, but in a question on the USMLE, this is my first sentence. My head is spinning from the possibilities. If I look down to the last line of the question stem, and the question says, which is the most likely overdose in this patient? And they say acetaminophen, salicylic acid, ethylene glycol, etc., etc. You know right away, as you go through this question, is what is the toxin I'm looking for? If I didn't think about that, I'm thinking about dyspnea, the million causes of dyspnea, nausea and vomiting, a million GI causes, tinnitus. Well, tinnitus is actually pretty specific. But otherwise, I would be wondering about the various long possibilities of the differential diagnosis. My trick that I will emphasize is that I read the first line of the question where they'll give you the patient's age, their gender, perhaps their ethnicity, and their chief complaint. And then you go down to the bottom line, and sometimes, not always, but very often, it'll give you a very good way to focus your reading of the question. So in this question, if I were to tell you that the question stated which is the most likely overdose of a woman with osteoarthritis, to my mind, an overdose in osteoarthritis is almost always acetylsalicylic acid. Can it be acetaminophen, another analgesic? It can be. But in general, think back to rheumatology. Do we use acetaminophen as our primary anti-inflammatory OA, osteoarthritis? No. Although acetaminophen is an analgesic, as is aspirin, the acetaminophen does not have anti-inflammatory properties, whereas the NSAIDs, aspirin, do. So, I'm thinking about osteoarthritis and evidence of an overdose. Right away, I'm thinking aspirin. She is fully alert and able to give a good history. Her only other problem is hypertension. Hypertension is interesting because there are a lot of antihypertensives that can cause problems, but usually not the pattern that you have here, especially the tinnitus. In fact, tinnitus would always make me think of either aspirin or sometimes quinidine, all right, or sometimes digoxin. But in this patient, osteoarthritis and tinnitus, I need to read no further to know that this patient is going to have an aspirin overdose. She's also on a wide variety of medications to reduce her pain. Okay, again, that should imply to you the possibilities. Well, what are the other possibilities? Well, we mentioned acetaminophen. Again, less likely than the aspirin in an OA, osteoarthritis patient. Aspirin, acetaminophen. What else? Maybe NSAIDs. Maybe this will be a GI bleeding question. Maybe this will be a renal insufficiency from NSAIDs question. Okay? The specific salicylic acid overdose properties that we're going to talk about do not apply to other NSAIDs. Okay? NSAID overdose, you don't get the tinnitus. You don't get the rest of the disturbances on the physical and on the lab exam that we're going to talk about for salicylic acid. Don't confuse salicylic acid and NSAIDs in terms of their overdosing properties. You'll confuse them because they're so often used in the same sorts of patients, and they both cause the important problems of GI bleeding and GI distress, sometimes even in a major life-threatening way. But the NSAIDs here do not cause, the NSAIDs we're using in osteoarthritis does not cause the clinical picture we're describing specifically for salicylic acid. So let's go back to this question. What else could she be on for pain? We said salicylic acid, we said Tylenol, we said NSAIDs. How about narcotics? If the pain is severe enough, she might be on narcotics. Now, do patients with narcotics come in with dyspnea and tinnitus? No. Can they have nausea and vomiting, which is nonspecific? Sure. Do they have dyspnea? No. As we'll talk about narcotics, obviously narcotics have respiratory depression. Her husband, let's go back to the question. Her husband says she was in so much pain lately that she took a half a bottle of extra pills a half hour ago. Okay? Now, if I were to phrase this question as what will be the first step in management, I just got an enormously important piece of information from this question. And that is what? That is that she took whatever she took, which the question is not telling me. They're asking me to figure it out. And I think it's acetylsalicylic acid, aspirin. But they're telling me, more importantly, if this is going to be a management question, that she took it just a half hour ago. So this is one of those lucky situations that I'm going to be able to clear the stomach while the medication is still in the stomach just a half hour ago with some form of gastric lavage. This patient is fully alert. What will I give her to empty the stomach? Ipecac. That would be the single best choice to do for this patient right now. Again, if they ask me what the diagnosis is without being told specifically, I'll say acetylsalicylic acid. What's the information here? Osteoarthritis and the tinnitus. The dyspnea, as we describe here, is actually from tachypnea, which is a more accurate way to describe what's happening. And that is because among the physiological, pathophysiologic effects that aspirin has, it will have, in overdose, a stimulus to the brain's respiratory drive. The respiratory center in the CNS is stimulated by acetylsalicylic acid's metabolite, which is salicylic acid. And so what the patient will have is tachypnea, which will cause which acid-base disturbance? It will cause a respiratory disturbance, obviously if it's tachypnea, will cause an alkalosis or an acidosis. Well, I'm tachypnea. I'm blowing off PCO2 rapidly and in great volumes. So my PCO2, my respiratory acid, falls. So I develop a respiratory alkalosis. At the same time, we know that the acetylsalicylic acid is metabolized to salicylic acid. This is an acid. So I'm going to develop a second acid-base disturbance, which is a metabolic acidosis. So the pH may often be given to you. An arterial blood gas, if it's given to you as part of an overdose, one thing to look for, because I'm not going to do an arterial blood gas routinely in overdoses unless there's severe respiratory depression, and I'm worried about CO2 retention. But if you get an arterial blood gas in a patient like this, you want to look for the respiratory alkalosis and the metabolic acidosis. That combination will give you a pH that can be high if this predominates. The pH can be low if this factor predominates, or it can be normal. So the actual pH doesn't help you. You'll have to look more carefully at the PCO2 and at the serum bicarbonate. Specifically, what kind of acidosis, metabolic acidosis is this? Is this a high anion gap or a normal anion gap? Well, it's very simple. I got extra acid floating around in my bloodstream, an extra anion that is not otherwise there. So that will cause an anion gap. And again, just to review, how do you calculate the anion gap? Sodium plus bicarbonate minus serum chloride is my anion gap. And normally it should be roughly 4 to 10, 4 to 12. If there are extra anions that are not accounted for by the chloride, like from a salicylic acid, my anion gap will be high, typically higher than 12, probably 15, 20, or even higher. Okay? And the boards might not tell you. The question might not say the anion gap is. They probably won't tell you what the anion gap is. But in general, when you're calculating any patients, if you're working on a patient with metabolic acidosis, whether it's a high anion gap or a normal anion gap acidosis, is what you need to ask yourself as the next step in evaluation of a metabolic acidosis. And if the anion gap is high, there are many potential causes for it. Aspirin is one of them. Just in way of review, what else that we talked about already can cause a high anion gap metabolic acidosis in terms of overdoses? Think about the metabolism of methanol. It's formic acid. So you get a high anion gap acidosis. How about ethylene glycol? It's metabolized to oxalic acid. High anion gap metabolic acidosis. All right? So there are a number of poisonings that can cause a high anion gap acidosis. I would think about methanol, blindness, formic acid, high anion gap acidosis. I would think about ethylene glycol, antifreeze, oxalic acid crystals in the urine, high anion gap acidosis. Isopropyl alcohol produces ketones but is not metabolized to an acid. So in a patient with isopropyl alcohol ingestion, you'll get a ketosis, a high anion gap, but the serum bicarbonate, the pH, will be normal. Okay, let's get back to our aspirin patient. Our aspirin patient, we talk about the acid-base disturbance, which is very suggestive of the aspirin overdose. What else might the patient have? Well, we mentioned tinnitus, which is not a very common side effect from many drugs, and certainly would make me think of the possibility of an aspirin overdose. The patient in very severe aspirin overdose might have non-cardiogenic pulmonary edema. I mean, the patient has a history of no heart disease, now presents with pulmonary edema, less likely. They're also at risk for developing CNS toxicity, and this is not so rare in the big overdoses, and it can present early on as just some confusion and more obtundation, even progressing to coma or seizures. But again, aspirin overdose will probably give you features in the question that, number one, wants you to recognize this aspirin, and number two, wants you to know how to treat it. If the patient is within the first hour or so, ipecac, because the patient will probably still be fairly alert within that first hour. If it's several hours or a day or so down the road, what will I give the patient to clear any residual aspirin that I haven't gotten rid of, or haven't absorbed yet? Charcoal. But beyond 24, 48 hours, it's unlikely there's anything left in the gut lumen, and I won't rush to do charcoal. The diagnosis, based on my clinical suspicions that we discussed, can be very well suspected from the history, the acid-base pattern, but the most specific way is obviously doing a aspirin level, which is easily obtainable and widely available. The treatment we started talking about, there's one additional specific treatment if it's not ipecac, if it's not charcoal, or if it's later and we're not going to give the patient charcoal because it's probably all been absorbed. This is a place where we will try and use the kidneys to get rid of salicylic acid. This is a place where we'll give up on chasing it in the GI tract. If it's a day or two later already, and the patient appears toxic from their aspirin, I can't get it out of the gut because it's all been absorbed already. Here I will alkalinize the urine, which will convert the salicylic acid to a more soluble form that then could be filtered out of the kidney. So I give the patient some sodium bicarbonate, I give the patient some furosemide, and I use the kidneys to flush out as much aspirin as I can. And if this doesn't work because, let's say, the patient has a history of pre-existing renal failure, here is some place where I'll have to resort to dialysis. Okay? So this is one of those infrequent situations where using the urinary system, making the patient pee, or clearing the serum with dialysis is effective. That's in a late aspirin ingestion. Let's move on to the next case. A 28-year-old man with a history of depression comes to the emergency department 1 hour after a suicide attempt with his tricyclic antidepressants and benzodiazepines. Now, if the question on the board was not so specific, they just told me here's a depressed guy and he's found unconscious at home or obtunded at home. Right away, I'm going to suspect, unless there's some other really suggestive feature like terrible cardiac disease, a depressed person found at home or anywhere unresponsive, think about an overdose with their antidepressants, or one of the other medications that depressed patients are often given for other coexisting symptoms, like benzodiazepines. Patient is very agitated, nervous in association with their depression, they'll often get benzodiazepines. But of the antidepressants, I'm thinking about one specific family, and that is the tricyclic antidepressants. Now, the question also tells me it's only 1 hour after a suicide attempt. Right away, I know that I'm probably going to start using Ipecac because it's still early. Unless I'm told that he is lethargic or obtunded. 1 hour, stuff is still in the stomach, but he's obtunded. I worry about aspiration with Ipecac. Again, clear the stomach in the obtunded patient with the big E-wall tube, but first, intubate the patient. Okay? We sort of run through many things that should be evident to us in this question before we even got to the final question. He is stuporous with a respiratory rate of 7. Okay, stuporous. I'm not going to give him Ipecac. If they're going to ask me how to treat, I'm going to use the E-wall tube. Respiratory rate of 7, respiratory depression. That's not a side effect of tricyclics, as we'll see. And I'm already told the patient is on benzodiazepines, so I know the patient is taking benzodiazepines, at least benzodiazepines. The question also gives me the benefit of telling me that he did take an overdose of tricyclics. He has a wide QRS. What do you do next? If the question did not tell me what medications the patient was on, told me he had a very slow respiratory rate, that would suggest that he has some benzodiazepines in the house. If they tell me a wide QRS, that suggests specifically tricyclics. And in severe cases, tricyclics can prolong the QT and put you at specific risk for a specific arrhythmia, which is torsade. Torsade de Pointes, polymorphic VT in a big tricyclic overdose. Okay, so let's talk a little bit about the tricyclic overdoses. They can, as we say, produce a prolongation of the QT, wide QRS, and ultimately torsade. They also have, tricyclics all have, to varying degrees, but they all should, you should assume they have anticholinergic effects. So what might they tell you on physical or in patient description that suggests that they have anticholinergic effects? Dry mouth. Anticholinergic, remember we use atropine for bradycardias. So that helps me remember anticholinergic, give tachycardias. So the tricyclic overdose has a tachycardia. Even before I do the EKG, I already know it's an overdose with tachycardia. The patient might, from the anticholinergic, have flushed but very dry skin. The patient's pupils are an important place to look in all overdoses because pinpoint pupils suggest one thing, narcotics. Dilated pupils, among other things, suggest phenothiazines. Excuse me, tricyclics. Okay? Tricyclics with anticholinergic effect, big dilated pupils. What else do they have? Dry skin, dry mouth, warm and flushed, and a tachycardia, all from the anticholinergic properties. The clinical diagnosis should be suspected based upon the clinical history, and again, a depressed patient. In severe tricyclic overdoses, We're going to have patients who have CNS effects, obviously, confusion, seizures, mental status changes of being obtunded, very lethargic. We can do serum blood tests for the tricyclics. In fact, they're widely available. That's how we monitor blood levels of patients who are chronically on tricyclics. And they are very specific. Obviously, if the level's not high, you better look for a different diagnosis besides tricyclic overdose. But it takes some time to get the tricyclic level back. You're not going to have that within a few minutes. You can have the QRS available to you with an EKG within a few minutes. So if I have a prolonged QT, a wide QRS, in this setting, tricyclic overdose. The treatment, again, gastric lavage here is effective. And what's unique about tricyclic overdose is that because of its effect to slow down the GI tract, to slow down peristalsis, I might maintain the benefit of gastric lavage for hours after the patient has done their ingestion. We talked about repeatedly, gastric lavage only within the first hour or so. In tricyclics, patient has a massive tricyclic overdose, the peristalsis slows down. So there might still be pills hanging out in the stomach 4 or 5, 6 hours later. And in the phenothiazine suspected overdose, gastric lavage can be attempted and get benefit from results of gastric emptying. Again, same principles apply. In the confused, obtunded patient, stuporous patient, Ewald, if the patient's alert after phenothiazine overdose, even if it's a number of hours later, you could still use Ipecac. So there's a specific approach to phenothiazines in terms of the EKG will give you the clue, the physical exam will give you a lot of anticholinergic clues, and the approach and management is different than the very general management in that we rely on gastric lavage for a number of hours. And lastly, bicarbonate here plays a principal, primary role in the management of a tricyclic overdose, in that if the patient has any cardiac effects, long QT, wide QRS, bicarbonate should be given right away because bicarbonate will protect the cardiac conduction system against the effect of the phenothiazine, of the tricyclics. So let's summarize the tricyclics. Fortunately, they're happening less frequently, but there are still many patients who are on tricyclics, particularly patients who have been on them for years. So you talk about chronically depressed people, they might want to overdose. You want to look for on the history, you're going to look for depression. On the physical anticholinergic effects, dry mouth and skin. They might be flushed, and they'll be tachycardic. An EKG is valuable here early on. We didn't talk about EKGs being important in alcohol, being important in aspirin. Here, the EKG is of primary importance, and an EKG will show me increased QT or wide QRS. And the treatment here is different than most other overdoses in that gastric lavage is effective even several hours after the ingestion. And here, bicarbonate is used if there is any evidence of EKG abnormalities. The last point I want to make with tricyclics is that patients who are on tricyclics, as with the patient in this question, are often on other medications. Monotherapy in depressed patients is not that common. Often benzodiazepines are on board, and you have to think about whether the benzo, things like diazepam, Valium, Ativan, all the brand names you're familiar with as sleeping medications. The benzodiazepines, you have to be thoughtful about who you're going to reverse with the specific antidote for benzos. We'll talk about benzos a little bit later when we talk about drugs of abuse specifically. But benzos, we do have a specific antidote, and that's flumazenil. Do not use flumazenil, a specific benzo antagonist, if the patient has been chronically on benzodiazepine, because there you risk the syndrome of an acute benzodiazepine withdrawal, which can be severe seizure-like activity. And again, you're going to remember the patient could be on other medications. Polypharmacy overdose is very common. And we talked about in the depressed patient the importance of tricyclics and any other accompanying meds.